Hi everyone, my name is Jack. I'm your host for today. I'm really excited today for the next installment of the APSC Leadership Series. Today we're going to talk about the most impactful cardiovascular trials in the last decade. The date stamp today is the 18th of February 2021 on a Thursday evening, 8 p.m. in Singapore, 7 a.m. in New York time. And this series is hosted by the APSC, endorsed by the Singapore Cardiac Society. My name is Jack. I'm an interventional cardiologist based out of Singapore, the current president for the Asian Pacific Society of Cardiology, as well as the president of the International Society of Cardiovascular Pharmacotherapy. Our guest today will be Professor Gregg Stone, the Director of the Academic Affairs for the Mount Sinai Heart Health System, Professor of Medicine of the Population Health Sciences and Policy at the Zena and Michael A. Wiener Cardiovascular Institute at the Icahn School of Medicine at Mount Sinai, New York. Our panelist for today is Dr. Gemma Figtree, Professor of Medicine, Northern Clinical School, University of Sydney, Australia, as well as good friend Quan Lee, Associate Professor of Medicine at the University of Arizona College of Medicine from the US. This webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. A bit of housekeeping here. This content is currently live streamed by Wonder Medicine, APSC Facebook and YouTube pages. For Singapore registered physicians, CME points will be submitted for attendees who are connected throughout the whole duration. You will then receive your certificate of attendance upon completing a survey sent by email after the webinar. After our discussion with Professor Gregg Stone, Professor Stone will come on live to answer questions. So please do key in all the Q&A for all the trials that you always have doubts about for us to answer live with discussion with Prof. Stone. A little pitch here for upcoming webinars hosted by APSC. On the 4th of March, we're going to host Sleep and Cardiology, a focus on OSA and links to cardiovascular outcomes. 6th of March, we have a transcontinental CHIP case sharing workshop, our test group. 12th of March, we have a live APSC bifurcation workshop with a focus fellow on bifurcation. We are doing a DK crush focus. 18th of March, we have a session protecting AF patients with diabetes beyond stroke prevention. So stay tuned and do join us for those events as well. So let's get started. And we welcome Professor Stone to discuss the impactful cardiovascular trials for the last decade. Thanks, Greg.
So I'm an interventional cardiologist, and I've spent my career of approximately the last 30 years after training both on the West Coast and the East Coast of the United States. I'm currently the Director of Academic Affairs at the Mount Sinai Heart Health System and Professor of Cardiology and Population Health Sciences at the Icahn School of Medicine at Mount Sinai. And I've done, again, in addition to take care of a lot of patients and performing many thousands of PCIs, I've spent a lot of time on clinical research, and I've led about 120 or 130 randomized trials, and also do a lot of education, including leading many courses, including the Transcatheter Cardiovascular Therapeutics course every year.
I'd like to just tell the audience, for those in Asia who don't already know Gregg, he has really widely published more than 2,000 manuscripts and abstracts. Besides being a director of TCT, he's a very experienced interventional cardiologist, and his focus areas are so innumerable, but just let me go through some of them, right? So his areas of expertise include acute coronary syndrome, AMI management, drug-eluting stents, bioresorbable scaffolds, left main complex multivessel PCI intervention, antiplatelet, antithrombotic pharmacotherapies, transcatheter mitral valve replacement therapy, intravascular imaging, IVUS OCT, NEARS, vulnerable plug diagnosis and treatment, new device angioplasty, including arthrectomy, distal embolic protection, thrombectomy, covered stents, chronic CTO devices, brachytherapy, saphenous vein graft therapies, left atrial appendage closure, contrast nephropathy, clinical trial designs, regulatory issues. So he covers a breadth and scope for cardiology. And to me, he's really been my go-to guy for what is to be the latest now and what is to be the future of cardiology. So he's really has, his trials are so impactful. He has really changed the course of cardiology practice. So there's no better person in my mind than him to go through what he thinks are the most impactful cardiovascular trials in the last decade. And hopefully we can together pick his brains about what is to come and what is relevant in clinical trials today. So Gregg, maybe I'll start with you. Let's say I'm a fellow, right? I am confused about the data coming out for stable coronary artery disease, multivessel disease, where the treatment lies. Right. So the last decade of trial, especially addressing multivessel left main disease in the stable situation, what trials do you think address those issues, particularly with patients with concomitant diabetes mellitus?
Sure. So when we think about the benefits of revascularization in coronary disease, we've really got to separate it out, and this was implied in your question, into stable coronary artery disease, or the preferred term now is chronic coronary syndromes, versus troponin-positive acute myocardial infarction, either non-ST segment elevation, ACS, or STEMI. And actually, one of the first trials that I was intimately involved in was the Pami Trial, which was now almost 30 years ago. And that really was the trial that established that primary PCI reduces mortality and reinfarction in compared to conservative medical therapy, back then thrombolytic therapy, and acute myocardial infarction with STEMI. You know, that now has been replicated in 23 randomized trials. And we have a dozen randomized trials in patients with non-ST segment elevation ACS, suggesting that revascularization with either PCI or bypass surgery is appropriate, reduces death and myocardial infarction. But so while we're on very solid grounds on revascularizing to improve prognosis in acute coronary syndromes, it's been more controversial about chronic coronary syndromes. And there, we could break it down a little further into those with relatively non-complex anatomy, more garden variety chronic coronary syndromes, let's say single, double, or simple triple vessel disease perhaps, and then those with either complex coronary disease, and that could be severe triple vessel disease, left main disease, decreased left ventricular function, and the extent to which diabetes, as you implied in your question, is a modifier of that continues to be debatable. So in the prior decade, the two probably most important trials in chronic coronary syndromes were the Courage trial and the Berry 2D trial. And as you know, Courage was a trial in a little more than 2,000 patients. And it took patients who had an angiogram and had stable chronic coronary syndromes, and then randomized them to PCI, mostly with bare metal stents versus medical therapy. And with follow-up to 5 years, even to 7 years, there was no difference in cardiac death or myocardial infarction. Patients who had PCI with bare metal stents initially felt better. They had less angina. They needed fewer anti-anginal meds. Their quality of life was better. But that difference really disappeared at about 3 years. And the results of Berry 2D was a different trial. Again, several thousand randomized patients. Now often with first-generation drug-eluting stents. And this was a population with just diabetes mellitus. And here patients were randomized to either medical therapy or revascularization with PCI or Cabbage. And the docs were free to choose PCI or Cabbage, and they stratified the randomization according to that decision, which was really based on the complexity of disease. And the overall trial was negative. There was, again, no long-term difference in cardiac death or myocardial infarction. Although in the bypass surgery stratum, the patients that had more extensive coronary disease, there was a reduction in myocardial infarction. So we had that trial. And then within the last decade, we had the FAME2 trial, which was a trial specifically saying if you took ischemic lesions and you did PCI of lesions that were ischemia producing versus non-ischemia producing, while there was no difference in death or cardiac death, there seemed to be a borderline long-term 5-year reduction in myocardial infarction. So we've got some hints that maybe if we're treating the more complex patients or patients with ischemia, that maybe there was going to be a benefit. And we know that Courage and Berry 2D in this regard really didn't enroll a lot of severe coronary disease patients and didn't enroll patients with extensive ischemia. So that was the rationale for the large ischemia trial, for which I was one of the co-principal investigators. And in ischemia, we didn't want the bias to exist where operators would only enroll patients that in their minds they knew had to, didn't need to be revascularized. And I think that was a real problem in Courage and Berry 2D. Very few patients with 90% proximal LAD stenoses were randomized in Courage and Berry 2D because the randomization was done after angiography. So in ischemia, we took patients with chronic coronary syndromes, and we took patients primarily who had no or mild symptoms. And the reason that we did that was that we didn't want a lot of crossover to revascularization in the medical therapy arm. And we also did a blinded CT scan in the majority of the patients. And the purpose of that was to, one, exclude patients who had normal coronary arteries. So the chest pain syndrome was either non-coronary or due to microvascular disease or spasm or something else. And we also wanted to exclude patients with left main disease, because in ischemia, we were only enrolling patients with at least moderate or severe levels of ischemia. So patients had moderate or severe ischemia and documented coronary disease by a CT scan. And then they were randomized to either an upfront strategy of angiography, followed by revascularization with either PCI or Cabbage as appropriate, versus medical therapy alone without even defining the coronary arteries by the angiogram. Just assuming that the mild chest pain or the ischemia was due to coronary disease, and treating with best medical therapy, including high-dose statins, antiplatelet drugs as appropriate, ACE inhibitors, beta blockers, et cetera. And patients were followed for a median of 3.2 years. And what we actually saw was that there were no overall major differences in cardiac death or myocardial infarction between the two different strategies. But interestingly, even though the overall myocardial infarction rates were similar, there was a slight excess of procedural myocardial infarctions in the urgent catheterization followed by revascularization strategy, whereas in the conservative strategy, there was an excess of late or spontaneous myocardial infarctions. So we were able to show that revascularization in chronic coronary syndromes does prevent late myocardial infarctions, very similar to what was seen in the FAME2 trial and in the complex surgical strata of Berry 2D. But there was no overall major difference in cardiac death or myocardial infarction. Now, what we did also see in ischemia was, despite the fact that these patients had very mild symptoms at baseline, about a third of them actually had no angina at all within the prior month, the patients who got revascularized on average felt better. They felt substantially better at 1 month, at 1 year, and at 3 years, and at the end of the study. And the number of anti-anginal drugs were less. So similar to what we saw in Courage, except the difference was prolonged. And it lasted throughout the entire study, as far as 5 years or more. And that was likely the reason it was prolonged in this trial and not Courage, was that Courage was only PCI and only was bare metal stents. Here we had drug-eluting stents, and we also had the most complex patients were treated with bypass surgery. So revascularization has certainly gotten better. And if you looked at the number of angina-free patients during follow-up, there was really a big difference in the percentage of patients that were angina-free at, again, 1 month, 1 year, and 3 years. And the more angina the patients had at baseline, the more likely they were to be angina-free during follow-up in terms of a relative risk reduction. And again, it was a persistent relative risk reduction. In contrast, patients that were asymptomatic at baseline, you really can't make them feel better. And so most of those patients stayed asymptomatic during follow-up with no difference between PCI and surgery. The last thing that we learned from ischemia was that there was really no overall difference in mortality. Despite the fact that these patients had on average double vessel disease. About a quarter of them had chronic total occlusions. Most of them had moderate or severe ischemia. They were chronic coronary syndromes, and with good medical therapy, their mortality was only about 1.5% per year, so about 6% in 4 years. And the mortality curves were superimposable with revascularization. So even though these patients had extensive ischemia, as long as they didn't have left main disease, they were not dropping dead. They were not having increased mortality. Although it's important to realize that we excluded left main disease, we excluded patients with left ventricular ejection fractions less than 35%, and very few patients had heart failure, very few patients even had a depressed LVEF. So this trial doesn't really apply to patients who've had prior myocardial infarction or heart failure. We have not yet looked at the overall outcomes according to whether or not complete revascularization could be obtained or not by PCI or Cabbage, and that analysis is underway. So in the bottom line, we've come a long way from courage and Barry 2D to ischemia, as our technologies have improved from bare metal stents, from balloon angioplasty to bare metal stents, to first generation and now second generation drug-eluting stents, and to bypass surgery improving. And as we've learned to risk stratify better which patients need surgery versus PCI. In chronic coronary syndromes, we've learned that at least patients without left main disease, even if they have extensive ischemia, if they don't have left main disease, if they don't have heart failure, we're not going to make them live longer. We may prevent late MIs, although at a slight risk of an increased risk of procedural myocardial infarction. So we don't overall do much to prevent myocardial infarctions. But we do make these patients feel better as long as they're having angina at baseline. So my bottom line is, and we'll get to the really complex patients in a minute, but for non-ST segment elevation ACS and STEMI, those patients we make live longer, and we prevent myocardial infarction, as well as angina and stroke and all the other benefits. For patients with chronic coronary syndromes without left main disease or extensive triple vessel disease, we don't make them live longer. We don't overall prevent myocardial infarction, but we certainly can relieve symptoms and improve quality of life in those patients who are symptomatic at baseline.
Thanks, Greg. That was fantastic. It was like a outline of the whole piece of 30 years of evidence into 15 minutes. But maybe I can do a deep dive now in this big topic, because I think among all the topics, Greg, this is a topic that confuses everyone. I would like to start on ischemia trial first, then moving back to summarize the rest of the impactful trials. Because ischemia led by Gregg is new, and a lot of people are confused about what to make of it, actually. We were one of the centers that was recruiting patients, and one of the difficulties was recruiting patients, because there's so much hesitancy from patients, from clinicians to say you got moderate to severe ischemia, let's randomize you to treat medically, even if there's no left main. So that was one of the real life hesitation. So some of the questions that's frequently asked, I would say, in people's mind is, the follow-up, median follow-up of 3.2 years, is it too short for a chronic trial to demonstrate mortality benefits? You think? Because it's quite consistent that we couldn't show mortality benefit even with earlier generation type of medical therapy against the contemporary intervention. What would you think is the optimum duration to show a mortality benefit, if any?
Sure, and it's a great question. We probably need to go out to at least 10 years. And again, because the mortality rates were so low overall, despite the extensive ischemia, we're really underpowered to be able to show a difference in mortality. And you wouldn't expect there to be a difference in non-cardiovascular mortality. You'd only expect there to be a difference in cardiovascular or cardiac mortality. So in that regard, there was a slight separation of the curves in cardiac mortality, favoring the invasive strategy, that is the revascularization strategy. Nothing that approached significance, but the curves were slightly diverging over time, and that correlated with the reduction in late myocardial infarctions, which favored the invasive strategy, which was also slightly diverging over time. So we are hopeful that we're going to be able to follow the ischemia patients out to 10 years. And we've, this trial, the Ischemia Trial, was funded by a large grant from the United States government. and we've applied for a follow-on grant to be able to follow those patients for another 5 years to see if that extra 5 years of follow-up will at least allow us to see a difference in cardiovascular mortality. Because if there is a difference in cardiovascular mortality, then I think it's reasonable to consider that all mortality is likely reduced had we randomized 10,000 patients instead of 5,000.
So can I also ask about this periprocedural and late MI definition? Are they the same definition? And what type of periprocedural MI do you think is actually significant to clock? For example, I think this is the part that I think in different trials, they have slightly different definitions, and it seems to confuse about what is relevant, what's not.
Yeah, no, it's a great question. Again, there's no one widely accepted definition of periprocedural myocardial infarction. It varies from almost every single trial. It varies from Courage to Berry 2D to Freedom to Ischemia, from Syntax to Excel. They've all been different. Non-procedural MI, the late myocardial infarctions, are pretty much all uniformly diagnosed the same, and that is a syndrome consistent with an acute coronary syndrome with positive troponins. That's pretty much, or maybe sometimes ST segment changes. That's pretty consistent. But procedural MIs, some trials have used very sensitive procedural MI definitions, such as the first universal definition or the third universal definition, which has a relatively low bar of troponin elevations, but it does require additional evidence of myocardial ischemia. Other trials have used a very high level of biomarker elevations required after procedural MI, with the rationale being that, like we described, and I was the senior author of the SKY document, which defined a clinically relevant myocardial infarction. And from doing a literature search, we found that really it was only the very large MIs that were associated with subsequent mortality, and with very similar definitions after PCI and Cabbage. And that's the other problem. Some trials have used very different definitions after PCI and Cabbage for procedural MI. So the field is confused right now about procedural MI. And in ischemia, we had a very large group of physicians, general cardiologists, interventional cardiologists, cardiac surgeons. And we agreed on a kind of a hybrid definition for the protocol definition of procedural MI, which was a relatively large elevation of biomarkers, not quite as high as the SKY definition, equivalent to about 5 times CKMB for PCI and 10 times CKMB for Cabbage. Multiply that by 70 times troponin, with additional evidence of myocardial ischemia. So there were different definitions for PCI and Cabbage. We also had a secondary definition of myocardial infarction, which was not exactly the same as the third universal definition, but was closer to the third universal definition. And the data that I just reported to you were the outcomes with the protocol definition of myocardial infarction, in which there was about a 2% increase in procedural MI with revascularization, and about a 2% decrease in late non-procedural MIs with a revascularization. Now, in contrast, if you use the secondary, more sensitive procedural MI definition, then you get a very different picture. Now you get a 5 to 7% higher rate of procedural MIs with the early invasive strategy, and that could totally change the conclusions of the entire trial. And it could make it look like the early invasive strategy actually caused harm compared to the conservative strategy. So which is the right answer? Well, we believe that the right definition of procedural MI should be a clinically relevant definition. It shouldn't just be like you lose 5 cc's of blood. It should have negative health consequences. And the best that we can do is relate it to subsequent mortality. And we've presented this data, and we have a paper that hopefully will be out soon in circulation that shows that it was only those large protocol definition myocardial infarctions that were related to subsequent cardiovascular mortality, whereas the more sensitive definition of lower biomarker elevations were not related to cardiovascular mortality. And we saw something actually kind of similar in Excel. When we talk about Excel, I can tell you we can go into a little bit about what we've learned in procedural MIs from Excel.
Yep. So this part has been confusing because I think when I read the ACC guideline document, it was, I believe, 10 times CK, MB, CK, and then there are 5 times there are troponin, there are CK, MB. And I think as practitioning interventional cardiologists, we know that there's some enzyme leak. If you define every enzyme leak as a periprocedural MI, there's no end to it. And we probably do need a real concerted definition of periprocedural. It's such an important definition. I'm surprised there's so much variance. So we will depend on you to lead us again for a proper definition of periprocedural MI. I think, can I just ask one last question for ischemia first? There are so many questions, but for example, what's the CT definition? Is it everyone getting a CT, and does the left main qualify as 50%? And of course, my question is, when does a ACS transit to a CCS? What is it a time base? Is it what markers do we use?
Sure. So a great question. So yes, for ischemia, left main disease was defined as a 50% stenosis in the left main. And the CTs were only performed in about 2/3 of the patients before enrollment in ischemia. Patients that had a creatinine clearance of less than 60 mLs per minute didn't have to have a CT scan. They could still be enrolled. We did discourage enrollment of patients who had stress test suggestions of possible left main disease, such as transient ischemic dilatation of the left ventricle or exercise-induced hypotension. So if you look at overall, we probably had about 1% of patients that snuck into ischemia with left main disease, but it was a very small number. And in terms of when you transition from acute coronary syndrome to chronic coronary syndrome, nobody knows that for sure from a prognostic point of view. Most people would probably tell you somewhere between 1 and 3 months that once you have not had an acute coronary syndrome for, let's say, 3 months for sure, now you are in the stable phase. And that's really based on studies that when you look at what happens with patients after acute coronary syndromes, particularly in the first month after an ACS, they've got a much higher likelihood of having a recurrent ACS, either from the treated lesion or from a new lesion. That gets us into the whole field of vulnerable plaque,
Yes.
which could have been great to talk about if we have time.
So I think my own read of what Gregg told me is that the trials have been quite systematic in defining progressively the subgroups and where is it safe and to do. But my read on a lot of trials was that it's a very selected group, I would say. If you look at the courage, it was really a fraction of total enrolled patients that were ultimately recruited. So I think it also is quite consistent with the practice in Asia, where to persuade patients to do just pure medical therapy without plucking a artery that is obvious and simple to do, and what Gregg said is quite safe as well, and you do achieve a late probably MI reduction benefits if you do it appropriately and safely in the intervention. The left main may be a separate subset, which I don't know whether Gregg wants to speak to, left main versus multivessel disease, or we should move on to the next bulk of AMI trials. Gregg, what do you think?
Very quickly, I will say, I think multivessel disease it actually turns out to be more complicated than left main disease. The left main disease is actually a large vessel. It's usually a short lesion. And even when there's a distal bifurcation involvement, interventionalists have gotten very good at treating the distal left main bifurcation. But where we don't do so well at is diffuse triple vessel coronary disease. When we've got to start putting in 60 centimeters of stents to treat 3 coronary arteries and chronic total occlusions, et cetera, sometimes 80 or 100 millimeters of stents, then we have high recurrence rates. We still have substantial stent thrombosis rates and restenosis rates, even with our best contemporary drug-eluting stents. And that seems to be a situation where bypass surgery is preferred. So certainly in the high syntax score patients and some of the complex mid-syntax score patients, I tend to think the prognosis is better after bypass surgery. But I think it also depends on whether or not you've got an interventional cardiologist, again, who can achieve complete revascularization, at least complete ischemic revascularization, if not anatomic revascularization. And in that regard, studies have clearly shown better outcomes if you can achieve complete ischemic revascularization compared to incomplete revascularization in chronic coronary syndromes, even in acute coronary syndromes, perhaps excluding shock, which we can talk about. In that regard, it's actually even more important after PCI compared to surgery. So if you're going to leave CTOs behind that you can't revascularize, send that patient to surgery. But if you think that the patient's got, 3 or 4 lesions, you can treat them with 40 or 50 millimeters of stents. They're not too complex. They're not, extensively calcified and tortuous and small vessel, et cetera. So you think you'll have a good long-term outcome with complete ischemic revascularization, then those patients may do quite well with PCI.
And I think the syntax score, residual syntax score, does give us some guidance on how to deal with this group of patients and not underserve them, especially if they have diabetes or other significant comorbidities. Can I just ask 2 questions about the left main then? For the left main intervention, do you have in your mind, based on the current trials evidence, what is the best stenting strategy for a double stent technique?
Yeah. So we don't know 100% for sure, but if you do have a true bifurcation lesion of the distal left main, right now the evidence from randomized trials would probably suggest the DK crush technique. From the studies that Shaolin Chen has run in China, both in the left main and outside the left main, there's been 3 randomized trials compared to either provisional or culotte, and the outcomes were better, with either less myocardial infarction and or less repeat revascularization with the DK crush technique. It's a little more complex technique. It takes more balloon inflations, but I think it seems like it's worth it. We'll see what happens with the EBC main trial. That's the one other big randomized trial that's going on that is not yet reported out. I don't know how much DK crush they're going to do in that. But right now, I would do a DK crush for most distal left mains that are true bifurcations that need 2 stents. The other thing, very, very important, if you're going to do a left main PCI, is to use intravascular imaging. And I'm happy with either intravascular ultrasound or OCT, but I mean, almost every study just shows substantially better outcomes if you do IVUS guidance of all complex coronary disease, but especially in the left main, where at least the data from Korea and from a meta-analysis suggests reduced mortality. So ensuring that you've got adequate lesion coverage and maximal stent expansion is very important in the left main.
So again, I think the context in Asia is that although the trial seems to suggest DK crush is superior, very few centers use it as a broad-based practice because it's not easy, it's more complicated. And I think imaging is really quite predefined. So I think the DK crush is built into the process of the procedure to use more imaging. It has multiple steps to ensure good apposition of both ostium. So it's built into the technique that you have a good result. I think that's the benefit of DK crush. But I would say, when I ask around my folks in Asia, very few people practice DK crush though. So it's
but I would challenge all those folks, and I think it's true in the United States and Europe as well. But I would challenge all those folks. It takes 15 more minutes. Let's say it takes 15 minutes, okay? I'd like you as a physician to look your patient in the face who's got left main disease and say, I'm not going to spend an extra 15 minutes and you're going to have a higher chance of a heart attack or a repeat revascularization related to your left main disease. I mean, when you think about it, 15 minutes, it's nothing in our lives to give that to our patients with such critical disease. Well, Excel was the largest trial of left main PCI versus Cabbage with 1,905 randomized patients. And it was an academically driven trial that was actually had 4 principal investigators, 2 cardiac surgeons, 2 interventionalists. And the trial itself was organized by about 100 physicians, including 50 cardiac surgeons and 50 interventional cardiologists. So it was very, very collaborative in terms of how the trial was carried out, what the endpoints were, what the definitions of the endpoints were, how we would report the trial, et cetera. And then when the final results came out at 3 years and 5 years, there were several controversies that arose from the trial. One of the surgeons became a little disgruntled. He had an erroneous idea about definitions being changed and made all sorts of crazy claims that he subsequently has retracted. But that was very distracting, unfortunately. The bigger issues were that the outcomes of the Excel trial, of course, have to rely on the definitions that we used. And when you looked at the results of Excel, there were better early results after PCI compared to Cabbage, but better late results after Cabbage compared to PCI. So the overall 5-year results were relatively similar. So this was a classic example of what we called non-proportional hazards, where the hazard ratio was lower for PCI early on and higher for PCI late. So how do you overall judge the results of a study when you've got those different phases? Well, of course, if you are going to have a complication, you'd rather have it late than early, because it's obviously exposing the patient to the complication for a lesser part of their lifespan. So you can look at something called the restricted mean survival time, which is basically the average event-free survival. And when we looked at that in Excel, it was almost identical. The average PCI patient had 5 more days of event-free survival than the average Cabbage patient, with the events being death, large MI, or stroke, which was the primary endpoint in Excel. And the confidence interval was wide, so there was no overall differences in the primary endpoint. But where the controversies have come is in what the definition of the procedural myocardial infarction was. And as I mentioned, the academic leadership, including the cardiac surgeons in Excel, we looked at the literature and we decided that the right definition for procedural MI should be one that was a large procedural MI amount of myonecrosis. So we had a CKMB basically of 10 times normal. And it was the same after PCI and Cabbage, because that's what the literature suggested, that it needed to be the same. It could be 5 times above normal, but then there had to be other evidence of either angiographic complications or myocardial ischemia. So we tried to come up with a definition that would limit ascertainment bias between PCI and Cabbage, and that was evidence-based. And all the Excel leadership agreed on that. But when the trial came out, and it was seen there was about a 40% lower rate of procedural MIs after PCI compared to Cabbage. And the main reason was because there was more graft failure than there was stent thrombosis. So the academic leadership of Excel, I think very professionally realized, wow, we have a problem after Cabbage. This is a place where we can get better. But some of the cardiac surgeons then started to create a story, well, procedural myocardial infarctions are not that important, and you used a definition that wasn't standard, even though it was a pre-specified definition that was evidence-based. And so that led to a lot of controversy. The other controversy was that when you looked at the 5-year outcomes, the trial, of course, is powered to show its main primary endpoint, which was death, MI, or stroke at 3 years. When we looked at 5-year outcomes, we looked at a lot of different outcomes that were not powered and all hypothesis generating. And so the New England Journal, for example, doesn't even allow you to report p-values anymore for anything else other than your primary and secondary powered outcomes. So we did note that there was a slight excess of mortality in the PCI arm. It was about a 3% difference after 5 years, so about 0.6% per year. But we looked at about 32 secondary endpoints at 5 years. And so the question you have to ask is, we didn't correct any of this for multiplicity. Is it a chance finding? So when you looked at cardiovascular versus non-cardiovascular mortality, you could see the biggest difference in the outcomes was non-cardiovascular mortality, in particular late cancers and late sepsis, occurring between 2 and 5 years after the procedure, which was of questionable biologic plausibility. Why should PCI versus Cabbage cause late infections or late cancers? When you've got an underpowered endpoint like mortality, this is where it's very good to go to the totality of the data that's out there. And there, as I mentioned, there have been 4 trials of PCI versus Cabbage that have now had 5 to 10 year follow-up, a total of 4,600 randomized patients. And when you aggregate all of those in a meta-analysis, you see there's almost identical long-term all-cause mortality and cardiac mortality between PCI and Cabbage. So Excel was a slight outlier in terms of that. But again, some of the cardiac surgeons in particular have glommed onto that one secondary endpoint and are ignoring the totality of the data and are trying to say, see, this proves there is an increase in mortality, which is not an evidence-based conclusion, but this is explaining why there has been a controversy. Given that left main disease is only 5 or 10% of revascularization for coronary disease, I'm kind of surprised this has led to the level of controversy it has. And I do think there are some underlying professional and personal reasons that have led to what I would view as somewhat non-evidence-based interpretations. But the bottom line is it has created a fair amount of controversy over the last year. I mean, we probably should say something about structural heart disease, because in the last decade, I think the major advances in the treatment of structural heart disease with interventional cardiology approaches has been really profound. And so it certainly is worth mentioning that. And I think that's really typified the importance of evidence-based medicine and the impact of cardiovascular randomized trials. And just to summarize, and I can do it relatively shortly, I mean, what we've seen in terms of transcatheter aortic valve replacement as an alternative and perhaps preferred alternative in many patients to surgical aortic valve replacement for aortic stenosis has really been astounding. And there's been a series of randomized trials done, especially with the balloon expandable SAPIEN line of stents in the partner trials, but as well as the Evolut stents with the initial core valve device that has evolved as well. Going initially from prohibitive surgical risk patients, patients that were too high risk, where it was proven that TAVR compared to medical therapy markedly reduced mortality and improved quality of life, to then comparing to high surgical risk patients compared to surgery, and then intermediate risk patients compared to surgery, and then low surgical risk patients compared to surgery. In every case showing that TAVR compared to surgical aortic valve replacement was of similar or improved outcomes in terms primarily of death or death and major stroke. And the way these trials have done, one after the other, I mean, all 1,000 to 2,000 patient randomized trials, very robust trials with excellent core lab analyses, serial echocardiography to look at valve areas and gradients, CT studies to look at valve thrombosis and leaflet function, et cetera, has really, within a decade, led to a transformation where the majority of patients with aortic stenosis are now treated with transcatheter aortic valve replacement. And that's only going to increase in the future. We're now running trials looking at the asymptomatic aortic stenosis patient, comparing TAVR to medical therapy, of looking at the heart failure patient with only moderate aortic stenosis. So it continues to evolve through strong evidence-based medicine. So I think really TAVR, aortic stenosis was the first, huge major impact into structural heart disease. We can talk about left atrial appendage closure. We can talk about pulmonary patent foramen ovale closure. But the evidence that's been generated for aortic stenosis with TAVR compared to either medical therapy or surgery has just been overwhelming.
Yeah, it's a fantastic summary. And I think the trials are really very well done, systematic, rigorous. And I would say it's probably the preferred treatment for the whole spectrum of severe critical aortic stenosis symptomatic. And I'd just like to ask you a little bit about, if we have both these partner trials as well as Evolut core valve series that demonstrate such good results, how about the other competitors? Do they need to demonstrate in the same series before they can gain the same acceptance, or is it only these two valves then based on evidence?
Well, no, there's always room for new valves. And and these valves are continuing to get better. They're continuing to become lower profile. They're, continuing to be more deliverable. They're, the SAPIEN valves in particular have evolved. And now there's a cuff put around the valve such that it decreases paravalvular leak, et cetera. There's still risks of pacemakers after the valves, somewhat more so after the self-expanding valves and the balloon expandable valves. So there are still risks of the valves. They still need to become smaller to continue to decrease vascular complications. We know that the femoral approach is a much better approach than the transapical approach. Transapical should disappear. So there's room for both the partner, the Sapien and Core Valve series to continue to improve. And there's room for other valves as well that are self-centering, that have less pacemaker and paravalvular leak rates, that perhaps are more one-size-fits-all, that maybe are easier to size, that have lower rates of rare cases of coronary obstruction or aortic root damage and dissection or rupture. So there's still room to improve. So I think the two series of valves are so well established now that it's likely that future valves will compare to them. If they were going to compare to surgery, then you'd have to go to other newer areas such as bicuspid disease, for which is still somewhat controversial whether or not TAVR is appropriate for younger patients with bicuspid disease.
Yeah, but I see more and more bicuspid aortic valve replacement using a percutaneous approach, I would say. I think just for the Asian audience, it's not in as big a way as in Europe and the States for TAVR, but the evidence is very strong and the field is evolving. The downsides of TAVR technique continues to evolve to improve the paravalvular leak, the severe complication, perforation, annular ruptures, and also yesterday we heard the popular TAVI results, defining even the pharmacotherapy around it. So I think this field has really evolved tremendously, like I say, over just 1 decade. So you're right, this is really one of the trials to lynch on as an impactful trial series to mention. I wonder whether you have time for the mitral as well as the simplicity series of structure, because these are also what is confusing my Asian population audience actually. Simplicity first, I would say, because it's easier to take up, but the trial results is hell of a confusing, I would say. So maybe Gregg, from your perspective.
Well, in many results, the mitral story has been more interesting than the aortic story. The aortic story is very simple and straightforward, but the treatment of mitral regurgitation, in particular with the MitraClip, and how that's evolved has been a more start and stop evolution. Starting with the randomized Everest 2 trial a year ago, which again was the first real randomized trial in the mitral space, which had about 3/4 patients with degenerative MR, 1/4 patient with functional MR due to heart failure, but low-risk patients where the comparator to the MitraClip was surgery. And it showed that here in that early learning period of the MitraClip that surgery was more effective than the MitraClip, although the MitraClip was much safer than a surgical approach, as would be expected, especially for bleeding, but surgery was more effective. But if you look back then, even in Everest 2, for the patients with functional MR due to heart failure, it looked like the MitraClip was doing pretty well. And that's actually how, over the next 5 years, Europe evolved and was widely using the MitraClip in functional MR and heart failure patients without real randomized trial evidence. And so then we got 2 randomized trials, COAPT and MITRA-FR, of patients with heart failure and functional MR. MITRA-FR in about 300 patients, COAPT in about 614 patients. And the results were very, very different. In the COAPT trial, which was the trial that I had the honor to lead, there was a marked reduction in heart failure hospitalizations, there was a marked symptomatic improvement, and there was a substantial reduction in mortality with treatment of secondary or functional mitral regurgitation in heart failure with the MitraClip compared to just optimal guideline-directed medical therapy. Whereas in the MITRA-FR trial, there was no such benefit. And on its face, the 2 trials looked relatively similar, but when you do a deeper dive into the trials, you actually see that they're quite different. And really, in COAPT, we were very, very careful to enroll patients who had severe mitral regurgitation and did not have end-stage left ventricular dysfunction. So not only did we have a lower cap of an ejection fraction of 20% on the ejection fraction, but we also had an upper size of the left ventricular end systolic dimension at 7 centimeters. In MITRA-FR, they had a lower ejection fraction range of 15%, and they had no cap on how big the LV could be. And so they enrolled patients with a lot more severe left ventricular dilatation and with a lot more moderate mitral regurgitation in COAPT. In COAPT, we basically required moderate to severe or severe MR according to these integrated multiparametric US echocardiographic criteria, where in MITRA-FR, they had a much lower threshold of what they considered to be severe MR. And I think that was the #1 reason that COAPT was positive. If you have severe MR and if you don't have an end-stage ventricle, those patients can truly benefit from interruption of the secondary MR into the pathophysiology of worsening LV overload and worsening LV dysfunction by reducing MR with the mitral clip. Whereas if you're already end stage and you don't have as severe mitral regurgitation, it makes sense that as the patients were enrolled in MITRA-FR, they weren't going to get better. There were some other differences in terms of background medical therapies. We basically enrolled in COAPT patients that had remained symptomatic despite all maximally tolerated guideline-directed medical therapies. So they really had nowhere to go with medical therapy. They could only kind of continue to do worse. Whereas in MITRA-FR, they didn't require patients having been maxed out on medical therapy. And there's some evidence that the control group got treated with more potent medical therapies than the treatment group. And that may have overcome some of the benefit of the MitraClip, because we do know that guideline-directed medical therapy does work in heart failure. And finally, there was a higher success rate and fewer complications and fewer recurrence rates of severe MR in the COAPT trial than in MITRA-FR. And I think it's because the US and Canadian operators that enrolled in COAPT had been using the MitraClip for, again, almost a decade. So they were very experienced with it, where the French operators in MITRA-FR, this was mainly the registration trial for the MitraClip in France, so they weren't as experienced with it. Their outcomes were good, but just not quite as good as in COAPT. So for all these reasons, I think that we now have a very important role of transcatheter mitral valve repair with an edge-to-edge technique in patients with heart failure and secondary mitral regurgitation. Of course, that same MitraClip device is also approved to treat degenerative MR patients who are at very high surgical risk. Although for patients that can get a good surgical repair, degenerative MR is probably still better approached with surgery than with a transcatheter technique. Although there are randomized trials ongoing to see if intermediate risk patients with degenerative MR might do as well or better with a MitraClip, now that, again, there's so much more experience with the MitraClip. And of course, there's all sorts of other new devices that have been introduced, other transcatheter mitral valve repair devices and transcatheter mitral valve replacement, which are undergoing randomized trials alone right now, either compared to medical therapy or compared to the MitraClip. And we'll see over the next several years where those are going to fit in.
So thanks, Gregg. That was a lecture by itself. And I'd like to thank Gregg again for his leadership to really clarify, because I think mitral is not as straightforward as aortic stenosis. Aortic stenosis, the indication is very clear. The patient selection is clear. For mitral, really, I think the selection is key. And I really congratulate and really want to thank Gregg for leading the COAPT trial that really clarified who, what, when to do this group of patients for functional MR. And I think our practice has really evolved to maybe how the patient with the required functional MR, how the patient with the prohibitive surgical risk degenerative MR. I think that's where I think the real balance number seems to be, rather than the European initially had I think probably over-enthusiastic implant in secondary functional MR all comers. I think that's where the issue was. Do you have time for the simplicity studies?
Very quickly, we can do the renal denervation, because the renal denervation I included in structural heart disease. It's perhaps not quite structural heart disease. It's its own category of a hypertension therapy. And there's all sorts of new interventional approaches to treat hypertension, from renal denervation to baroreceptor modification and others. But renal denervation, of course, has been most widely studied. And it's been a fascinating story because of what it means for evidence-based medicine and randomized trials. And of course, you know, the story was that in many patients with hypertension, there's excess sympathetic output, and a lot of that comes from the kidney. And there was experimental evidence that decreasing sympathetic output from the kidney by renal denervation would decrease blood pressure. And then there were unblinded studies that were run, which were Simplicity 1 and Simplicity Hypertension 2, which were markedly positive and showed you know, office blood pressure reductions of 20 to 30 millimeters of mercury, ambulatory blood pressure reductions of 10 to 15 millimeters of mercury, 90+% of patients responding, almost too good to be true. But people, I think in retrospect, forgot that famous saying that when things look too good to be true, they probably are not. But people were so excited by the results of these unblinded trials of renal denervation that they didn't even give possibility to the thought that perhaps a lot of this is because of the unblinded nature, the open label, uncontrolled nature of these studies. So then Simplicity Hypertension 3 was designed, and that was a sham-controlled trial of renal denervation using the original RDN catheter. And it actually showed that there was no substantial difference in blood pressure reduction. And this was just a shock to people. There was blood pressure reduction, a moderate amount of blood pressure reduction in the treatment arm, but there was also a substantial blood pressure reduction in the control arm, and the difference between the change in the two arms was not statistically significant. And so everybody then was talking about, well, perhaps the technique wasn't optimal, perhaps we weren't denervating enough, we weren't denervating the branch vessels where a lot of the renal arteries live. Perhaps there wasn't enough training of the operators. Perhaps we had too many patients with isolated systolic hypertension. We didn't have the right sorts of patients. There seemed to be racial influences, which may relate to the underlying etiology of hypertension. Again, you know, you would only expect renal denervation to really be beneficial when there's sympathetic excess, et cetera. And there's no real way to gauge or to measure when there's increased sympathetic output coming from the kidney. So there was regression to the mean and other clinical trial considerations, including placebo effects, Hawthorne effects, nocebo effects. We can go on and on and on about this. So there had been about 25 or 30 different companies which had developed different types of renal denervation systems. And all of a sudden, after Simplicity Hypertension 3 came out, the vast majority of those just disappeared. And it looked like it was very possible that, that renal denervation was going to be relegated to some of those other therapies, such as laser myocardial revascularization, another therapy that I was involved in about 20 years ago, which we thought was going to be great for patients with refractory angina, except when we applied it to a sham-controlled trial, it didn't work. And it looked like renal denervation might be falling into the same category. But I will give particularly Medtronic tremendous credit. Again, to their credit, they did not give up, and they approached every aspect of it by designing a better catheter that could lead to multiple radiofrequency ablations simultaneously, the spiral catheter. They did more pathologic studies to see where the renal nerves were located, how far they were away from the adventitia, how deep the ablation had to be, how many ablations there should be. They fine-tuned who the patients were. They then did a series of studies, very careful studies. First, an off-med study of patients with mild to moderate hypertension where the meds were weaned. And then a sham-controlled trial was done of renal denervation with the spiral catheter versus sham to try to understand whether or not the device even worked. And then they did an on-med a trial as well. And those were both pilot trials. And in those pilot trials, they did find when you optimize many of these features and try to overcome the limitations and take the learnings from Simplicity Hypertension 3, that indeed renal denervation does work. It doesn't work to the extent that we were hoping that it worked. It seems like it reduces ambulatory 24-hour blood pressure measurements by about 4 to 6 or maybe 7 millimeters of mercury. So in this regard, it's probably as effective as one drug, but it does work. And it has very, very few complications. And this has now been evaluated in the pivotal Simplicity Hypertension off-med trial and shown to be effective. And we're waiting for the pivotal Simplicity Hypertension on-med trial. It's also been shown to be effective with one other system, with the Radiance system, which is a radio frequency ultrasound balloon, which has a different method of ablation, but seems to be approximately equally effective. So we've learned a lot from this whole series of 15 years of experiments. First of all, learning about don't get too over-enthusiastic, especially from uncontrolled open label trials. We have to understand the placebo and Hawthorne and other effects and regression to the mean. It's so critical to identify the right patients, to understand the pathophysiology, to have the right technique down, and then to test it in the appropriate sham controlled trials very carefully. When things look like they're too good to be true, they almost always are. But fortunately, the field persisted, and we've learned that there is likely going to be a role for renal denervation for treatment of hypertension. It's still being exactly, I think, crystallized and specified as to where that will fit in, either for refractory hypertension or severe hypertension or patients who can't tolerate multiple medications. But I think it will have a role, and it's been very instructive in terms of how to integrate all that information in a new interventional cardiology device to bring it forward to clinical practice.
I think the confusion for the Asian audience is that initially we thought, like you said, it was we believe it was as good as it was. And after Simplicity Hypertension 3, the series of trials really confused a lot of my Asian colleagues because we're not too sure what they're trying to get at. And we are not too sure how to define the patient subgroup. Is it the truly refractory hypertension or the mild moderate, and where to pitch this device therapy at? I think we are still waiting for some formal guidance and maybe more definite trial results to define the patient subgroup for the Simplicity device. I think the device has become so much easier to use, so much faster, so much safer. But again, Greg, we need patient selection.
Right.
Yeah, so I think that's really the crux of it. I like to finish up by saying that I think my previous bosses have told me many times, what is good now was at one time new, like
Right.
Teva. But what is new need not always be good in the future, just like the Simplicity. I think we're always hopeful. I think interventional cardiologists like all this new stuff, new toys, and we're very privileged to have leadership like yourself, always pushing the bounds and showing us the way. And I personally, as a trainee since I was a fellow, has benefited tremendously. And my practice has changed based on the trials we have done, Greg. So I don't know how you feel. It must be an amazing feeling to be able to drive at that level. And really want to applaud you, and please keep on the good work.
So thanks, Greg, again. That was tremendous. It was really 1 hour. Rewatching the interview with Greg was really, again, very insightful for me. It never amazes me how much I learned from Greg. So we welcome Professor Greg Stone to take some live questions. We're just going to use maybe 15-20 minutes of Greg's time live now so that he can take some questions. To kick the ball rolling, Greg, there's one question from Muhammad Awasi about the subgroup of patients with severe aortic stenosis and severe coronary artery disease. Based on evidence, which should come first? Should we treat the coronary artery disease first or the severely stenotic aortic valve? Greg?
So hi, well, thank you for having me. I'm not sure you can see my video. I don't know if it's working.
The video is off, but we can hear you very well though.
Oh, I'm sorry about that. It was working during the setup. But anyway, it's wonderful to speak to you today, and thank you for that very special interview. We covered a lot of topics in a short period of time. And this is a very difficult one that you now bring up. Treatment of coronary disease or severe aortic stenosis first. And I presume you're talking about patients who have both severe coronary disease and severe aortic stenosis that clearly both need to be treated. If that's the case, I would say that in most situations, we are probably treating the coronary artery disease first. And the reason is because sometimes it can be difficult to access the coronary arteries through the valves, depending on which valve is used and whether or not the takeoff of the coronary arteries are low versus high. It's just easier to access the coronaries without the TAVR structure in place. But that being said, that's not the situation in all cases. If, for example, you have moderate coronary disease and you have very severe aortic stenosis that's hemodynamically, flow limiting, and the patient's in heart failure and or borderline hypotensive, then of course we'll do the valve first. Sometimes we'll have a hybrid strategy where first you'll just do a valvuloplasty just to relieve the aortic stenosis, then do the PCI, and then do the TAVR. So I think you have to individualize it for each individual patient.
Thanks, Greg, for that answer. Mohammed again asked about renal denervation, what you just presented. And he's asking about patient selection again. In his mind, he's not sure whether it's truly reserved for refractory hypertension or is it just plain systolic hypertension? Anyone would benefit? What are your thoughts on patient selection again?
Yeah, no, it's a great question, and we're actually still working it out. To be honest with you, the pivotal trials are still underway. It seems as if, to me, its most valid use is going to be for patients with refractory hypertension. Either they are on 3 to 5 drugs and their blood pressures are still in the 160s, 170s, you just can't get them down. Whether that's because they are truly refractory or non-compliant with their drugs is probably less important than the fact that we now have a therapy that is a one-time treatment that can't help them. And it does look like that the effects are sustained. It's not a huge effect. It's about equivalent to taking one drug. At least that's what we see so far with the current randomized trials. It's possible that some of the newer devices, for example, the Peregrine catheter that uses a circumferential alcohol ablation of the sympathetic nerves, may be a little bit more effective, but we have to see from the randomized trial that's done there. So I think for me, it's going to mostly be patients that are, have refractory hypertension.
Yeah. So I think when drugs have failed, they're compliant. I think that's where this therapy may have a role. Quan, you're there on the panel. Do you have any questions to point to Greg?
Yes, Greg. I really appreciated your leadership over the years with regards to left main versus Cabbage question, especially with regards to the Excel trial. And for me, despite the controversy, with what we've learned about optimizing PCI over the ensuing years, I honestly don't think the question is fully answered yet. Where we've learned about DK crush and how much it's better, we've learned about IVUS, and now this emerging field of post-PCI physiology optimization. And I think there was a review article in JACC Interventions that just came out that you were a senior author on. If you had to redesign the Excel trial in 2021, which of these would you have mandated be performed, in the left main and also in the additional downstream vessels? So like throw that out as a question.
Yeah. No, you're absolutely right. That's the great thing about the PCI field. The technique keeps getting better. The outcomes keep getting better. In the trial, we strongly recommended, but we didn't mandate intravascular ultrasound use. And so it was used in about 3/4 of the patients. And then it was used primarily in the left main and not necessarily in other non-left main coronary arteries. And we strongly recommended, but did not mandate use of physiology, particularly for identification of borderline lesions, not the left main, but non-left main lesions that needed to be treated. Now, of course, we're entering into an era where maybe, and a big maybe, post-PCI physiology is going to be useful. And we're going to be randomizing 3,000 patients in the defined GPS trial patients who have a good angiographic result of after PCI to then undergo post-PCI IFR testing versus not, and further optimization on the basis of post-PCI IFR. And then finally, you bring up the very important question as to what is the optimal technique for the distal left main. And at least right now, all the data is pointing to DK crush. But of course, all the operators need to really know how to do that technique and do it well, with 2 crushes and 2 pots and imaging, et cetera, to get those kind of results. So if I were to redesign Excel now with all of that into account, I would mandate intravascular imaging instead of just strongly recommend it, and really spend a lot of time training the operators as to how to get the most out of intravascular imaging and use it not only for left main optimization, but for any moderate to large vessel optimization as well. We would mandate intracoronary physiology for the assessment of borderline lesions, probably those that are 50 to 80% diameter stenosis. We would probably strongly recommend DK crush. DK crush was used in probably almost no patients in Excel. A very small percentage of patients got crush. We didn't capture how many that were DK crush, but that's way before DK crush was really caught on. And we didn't have sites in China, or Taiwan. So I suspect that it was a very small percentage of patients that had DK crush. So we would strongly recommend DK crush, probably not at the point where we can mandate it yet, absent a large international trial confirming Shaolian Cheng's findings. And I think it's too early to recommend post-PCI physiologic assessment, but that's going to be coming in the future randomized trials.
Could I follow up one more question? During the Excel presentations, I noticed with some interest that there was some struggle with the ability of the clinical sites to correctly syntax categorize their patients into the appropriate low, intermediate, and high group. And in routine clinical practice, we also notice the same trend. The syntax score is extremely difficult to generate with good inter-observer agreement. It's so central, as you alluded to early on as well, with regards to the appropriate decision-making, surgery versus multivessel PCI, and really complexity of coronary disease is the primary differentiator between which is the appropriate direction, and yet we struggle so much. How do you think we can improve this use of the syntax score? I try, and I'm at an educational institution, and we teach our fellows to use the online and go through all the things, but it's just very difficult to use still. And I suspect that's true around the world as well. In the heart team score meetings, I'm not sure anyone is actually really using syntax scores appropriately. Do you think it might be that we mandate that you have an app that you upload your films and a core lab then sends you back your syntax score? Or maybe it's time to develop a new score or use artificial intelligence for processing of uploaded angiograms, perhaps?
Well, as you know, the sites tend to underestimate the syntax score. And when we looked at where the error was, it was mostly in twofold. One, it was mostly in assessment of diffuse disease in small vessels. Two, there are some side branch issues where smaller side branches were not counted. So, the syntax score, uses a 50% diameter stenosis in a vessel 2 millimeters and larger. So if there were small side branches with a 60% stenosis, the operators didn't necessarily count those. And then three, there was complexities for the operators in left main trifurcation disease. They always didn't do the syntax score right there. So as a result, in the Excel trial, which was supposed to be just low and intermediate syntax score patients, as you know, a quarter, full 25% of the patients were high syntax score patients. Now, that being said, they're on the lower end of the high syntax score. They're not in the 50s and the 60s. They may be in the high 30s. And the systemic errors that I just described are mostly lesions that you're not going to treat anyway by PCI. And if you looked at the outcomes in Excel, according to the core laboratory syntax scores, even the high syntax score patients, that had non-inferior outcomes compared to surgery for death, MI, and stroke at 3 and 5 years. They had very similar outcomes. So there wasn't a major gradient from low to intermediate to high syntax scores. So that doesn't mean that we can ignore the syntax score, because again, importantly, the operators thought these were lower intermediate syntax scores. So the bottom line answer to your question is that I don't think it's practical to require uploads of hundreds of thousands of cases to a core laboratory. I do think the syntax score has utility, and we should go on and continue to analyze the syntax score. But I also think that operators, because of the syntax score, are getting pretty savvy and can look at their patients now and tell, is that a low risk patient, an intermediate risk patient, and a high risk patient? You know, in the syntax trial, we had too much hubris. We thought that, you know, Taxus drug-eluting stents were going to totally equalize the playing field compared to bypass surgery. And we learned there was still a bridge way too far. And the really complex patients, the real high syntax score patients, should still undergo surgery if they're surgical eligible candidates. And I think most people can assess who those patients are. And to me, the litmus test is, do I think I can get complete revascularization? We know that percutaneous and surgical, but especially complete revascularization by PCI is strongly associated with a better outcome, lower rates of cardiac death and myocardial infarction. And so you've got to ask yourself, am I going to be able to open up the chronic total occlusions that go to viable territory? Am I going to be able to treat the diffuse disease and the complex bifurcations that are there? And if I think I can get complete revascularization given my own skill set, then that's probably a reasonable patient for PCI. If I think that no, there's some CTOs that are just too tough, and maybe I try to convince myself maybe those CTOs aren't that important to the patient, you know, that's probably not in the patient's best interest. And if I don't think I can get complete revascularization, I should probably refer that patient to surgery.
Thanks, Greg, for that very complete answer. Again, we're running out of time, so maybe one last question, and we should close to not tap on you too long. What is your read on the pharmacotherapy around the PCI group of patient? There's always a tension about extended depth versus a shortened depth for the high bleeding risk patients. Maybe a simple message on your read of the trial data. Which group of patients should we be practicing an extended depth, and which rough group should we really shorten it to a bare bone minimum?
Yeah, so I think there's less and less data to support extended DAP. When you really look at it, in most studies, extending DAP does reduce very late myocardial infarction and stent thrombosis rates, but not so much with second generation or contemporary drug-eluting stents. And they do it at the cost of increased bleeding. And that increased bleeding seems to offset any mortality benefit from reducing the MI and stent thrombosis. In fact, the net effect probably favors not having prolonged DAP because you don't want to have the bleeding. So the bleeding risk really dictates the conversation. In patients that are at moderate or increased risk for bleeding, they should be treated with short DAP. And whether that is 1 month DAP or 3 month DAP, you know, I might do 1 month for the chronic coronary syndrome patient, 3 months for the ACS patient, and usually we'll drop the aspirin. For the patient who is not at high bleeding risk, then I think, you know, 6 months is still fine for chronic coronary syndromes. 1 year is probably still fine for the acute coronary syndrome patient. I wouldn't treat too many of them beyond 1 year, except for the occasional ACS patient who's got just a lot of diffuse disease and maybe continues to have a high CRP and his risk factors are not under control. Then that patient may benefit from prolonged DAP. But in general, I'm kind of between the 1 month to 1 year range for most of my patients.
That's great. Thanks again, Greg. I think I'm afraid we have to close the session. We've come to 90 minutes. And again, I want to congratulate and really thank Professor Gregg Stone for his continuous effort in leading trials as well as education. It's 7 a.m. for him in New York, and he has gotten out of bed to really educate and share with us his experience in Asia. And I'm very appreciative of his time and efforts in this arena. So again, Professor Stone, from the bottom of our hearts, thank you very much. And we hope to tap on you soon again. For those in Asia, happy Chinese New Year, and thanks for joining us at night to listen to Professor Gregg Stone. So thank you very much, everyone.
Happy Chinese New Year, everybody.
Thank you very much, and do keep safe. Goodbye.
Thank you, Jack. Fun. Bye.
Bye-bye.